Hey, welcome back. It's good to be back, and I truly, from the bottom of my soul, apologize for the long wait between episodes. But my wife was able to scrounge up enough spare change to pay those ransom demands, and here we are. It's amazing to find out how much change you can find between couch cushions. All right, to be honest, I was afraid I'd never see your smiling faces again. See the true power of positive thinking. Tonight, we have a panel discussion by special request. That's right. There was enough interest from employers in radiation oncology divisions that they pulled me aside and, well, held me hostage until I agreed to those demands to have a discussion on this topic. So here we are. We have three panelists with us tonight. We have Dawn Eskridge of Norwood, and she will be. Oh, let me put her banner on. Dawn is the Senior Vice President of Recruitment and Mid-Revenue Cycle Staffing at Norwood, www.norwood.com. And she's going to be talking about the hiring process and expectations for productivity, skill set, and skill set from her perspective as a coding recruiter.
Thank you, John. Thanks for having me.
Yeah, glad to have you all here. Susan Sawinski is next up to bat, and she is a coder for the Toledo Institute, and she has got a bunch of alphabet soup after her name. So she's also certified in hematology as well as radiation oncology, and a couple other things in between. But she's a radiation oncology coding specialist and revenue cycle professional at the Toledo Clinic, as well as the current educational officer for the AAPC Toledo chapter. There's a lot of Toledo's mixed into that biography. I love it. And then we have Heidi Vance. Heidi Vance, Bachelor of Science, CPC, CPTO. She's a revenue cycle management, healthcare compliance, and radiation oncology specialist. And she's actually a radiation oncology SME in this field. So we brought them on to talk about their interests. So you don't want to hear me rambling on and on about the three panels. So let's talk about radiation oncology. So Susan and Heidi, let's start with what radiation oncology actually is. So what are some of the common treatments and conditions for these services? And I'll just let you guys run with it.
Radiation therapy is, you might commonly know, would treat neoplasms, a different type of neoplasms, anything from prostate cancer to brain cancers or metastasis and everything in between. And also it can be used for some non-cancer conditions. I have one of my physicians will treat hypertrophic scars and keloids, and they have some success with that. Pending insurance approval when that happens, of course, but it can be done. It's something that maybe people aren't aware of. But the treatments, we would do 3D treatments or IMRT, which is intensity modulated radiation therapy, or stereotactic body radiation, which is similar to like a radiosurgery, where they really focus those beams in some concentrated brief treatments. So it's a very interesting field, I think. But I'll let Heidi talk.
Yeah, just in addition to that, oh, go ahead. I'm sorry.
I was going to say, what's your take on radiation oncology and what do you see in your field?
Yeah, I would say, of course, neoplasms head to toe, benign sometimes even. And that's really kind of the bread and butter, I think, of radiation oncology is cancer, obviously. But I did see we would do heterotopic ossification, prophylactic radiation for that. Sometimes if somebody was in an MBA and had a really traumatic hip dislocation and maybe a break in their femur or something, sometimes to enhance healing and prevent ossification, they would run the patient on over to the clinic pre or post surgery. It kind of depended, and do a one-time treatment for them. So that was maybe more some of the unusual one-offs, although they were becoming more common, I think. And we also had a specific kind of radiation that we would do sometimes for patients who have hemophilia, because sometimes blood will pool in their joints, making it hard for them to move. Mm-hmm. And so when that particular type of radiation can't even think of the word I need for it right now, but when it became available, which isn't very often, then they would call all those patients and have them come in and give them a one-time treatment to give them relief in their joints. So those are some of maybe the more unusual things you don't hear very often when you think of radiation.
All right, so there's a lot of different things that you guys can treat. And it looks like we have somebody coming in from, we have Liz Reed from Dumfries saying hi. But let's say hi to Dawn and let her talk a little bit about this job market. So job market wise, what is the demand for radiation oncology at the current moment? Is this something that people should invest themselves in learning?
Well, I highly encourage any coder to continuously learn and continuously to learn different modalities and different multi-specialties. I know that radiation oncology tends to be a little more segregated and they like really highly specialized in that. And so because of that, there tends to be not too many in the market. And so it makes it a highly sought after skill. But I wouldn't encourage someone to just say, that's all I'm learning and that's it, unless you are 20, 30 years into your career and you just love it and you're passionate about it, things like that. If you're starting your career, I would definitely encourage everyone to learn a broad spectrum so that you're not pigeonholed. I want you to be able to work continuously in your career. And certainly there are radiation oncology coders who have made a fantastic career in cancer centers or in treatment centers, that type of thing. So if that is your passion, certainly do that. But I would certainly I would definitely recommend someone to at least learn it and get into it and try it, because the more you learn, the more opportunity you have to make an impact on patients and on the hospitals and to continue your career in a broader scheme. So yeah. Definitely don't ignore it. Yeah.
Yeah, there's a need. So
definitely. We actually have openings right now that we are interviewing people for. And we get those quite frequently. And because they're specialized, they tend to stay open a little bit longer because we're trying to find someone who is very specialized in that. So it's definitely a marketable skill set and knowledge set to have. Yes.
Awesome. So back to Susan and Heidi. So I have this strange feeling that the coding process for radiation oncology is like really super complex and ultra technical in nature. Is this some kind of truth to this, or is that just some myth that just made its way into my mind and I'm scared to begin on this? What is that in actuality? Is it complex, or is this something that's completely doable and manageable?
I personally think it's pretty complex. I think it also depends on maybe the facility that you work at. I have worked places where they just did prostate and maybe a few bone mets, and they primarily did IMRT, the occasional SBRT treatment. And so if you know the codes and you understand the process from beginning to end, then it can become repetitive. I also worked at a university, so we did everything. We did everything and then some. And so, and they, if you're in an academic university, they're always looking to push things forward and move medicine forward. And so things change a lot. And they, some of those great doctors out there who really want to cure cancer are always changing things. So just when you think you figured it out, they change something, and maybe you're used to one plan is pretty traditional for treatment, and they are doing adaptive radiation now, where every time the patient comes in, they replan. So if you understand the process for each treatment, then it becomes less complicated. But I would say to learn it really well and to learn all the modalities, it takes time. It's not I don't think it's a quick specialty to learn personally.
I would agree. I came into actually coding radiation oncology without any experience in that particular specialty, other than years before I had maybe built some gamma knife, but not coded it. But my employer had a need to hire a coder, and as Dawn had mentioned, there is a demand for people with experience in it. And I knew my boss through my local chapter, and she was familiar with some of my background and knowledge. And she said, I think you can learn this. Do you want to give it a shot? And I said, sure. It's a small group of codes. How hard could it be? And then I sat down and started reading and started learning, started getting my hands into the documentation. And I thought, okay, I underestimated that. But as I've picked it up and learned it, I've loved it. It's a very interesting specialty. So if you really are interested in learning it, I would recommend to anybody that they give it a shot. Maybe check out some webinars.
And Susan, you brought up a good point, that you had a good mentor and someone that believed in you and someone that invested in you to learn that. And you had a base set, right? And then you expanded into that. And I think that that's a really important track for everyone to think about as they're coming into this. Yes.
Yes, exactly. I had a lot of experience working in healthcare, just not in that specialty. So I just had to learn the nuances of the specialty as opposed to learning everything all at once.
Yeah.
So we had talked about some of the things that are treated in some of the conditions, but what are the biggest concerns with the anatomy and its relation to the coding aspect that a coder should take step? I'm having difficulty speaking today. Wow. I have a whole week off or 2 weeks off, and now I can't do this anymore. Wow. So, anatomy in relation to hematology, oncology, or oncology and radiation oncology. What are some things the coders need to know, and how should they prepare when they do this undertaking with radiation oncology?
Well, go ahead, Susan.
I was to say, I think that having a solid background in anatomy and pathophysiology is really good, because in order to pick up those neoplasm codes and know what they're treating, you have to be able to interpret the very specific documentation for the treatment areas and know, if they're treating the cranial lesions or anything, or just for neoplasm coding. It's important to be able to code to the specificity. You have to understand the anatomy that's involved in the documentation. And Heidi's thoughts.
Yeah, I would agree. I think, especially as I was thinking about that question, that sometimes, some of the anatomy is real obvious, it's organs, but sometimes, cancer doesn't just hang out in the easy places to code. So I think about like the central nervous system and how the codes can get real specific there. Is it the nerve or the nerve sheath? And so really learning your anatomy, and I suppose, surrounding yourself with other coders who are experienced in it, who can help you see like that you're going to get down to kind of the nitty gritty of where that is. Or if there's a neoplasm that's, in the abdominal area, if it's in an organ, that's obvious. If it's, know your lymph nodes really well, because cancer goes to the lymph nodes. And so, know where those are all located. And I can't stress probably enough in knowing anatomy and really learning about disease process with cancer too, to understand that. That helps when you're reading the documentation from the physicians.
I agree with Heidi. The radiation oncology documentation is very complex, very technical. So to have a good background in anatomy and physiology and disease processes will help you be able to understand what you're reading.
Yeah, I work in cardiology, and I'm used to seeing abbreviations. But those abbreviations usually have some kind of like formatted, logical like thing you can read from. That they have a CVA, cerebral vascular accident. But sometimes with the radiation oncology and oncology, like you see like TC127A class disease. Is there some kind of methodology to that? Like sometimes I don't know if they're talking about labs, and I don't know if they're talking about a core sample. Do you know where I'm going with this?
Mm-hmm. Yeah, sometimes that they will they'll put in parentheses the cancer, the tumor, T for tumor, and then a number behind it, and then they'll follow it up with, if there's metastasis and different things. And so you learn, sometimes that's a clue, if it's at the beginning of the documentation for what you're going to be looking for, like where is that tumor, where are the metastases, different things like that. So yes, there's a lot of abbreviations and a lot of, there's staging for the cancer, and there's severity of the cancer, and some of those things apply to coding, and some of it's just information that you're gathering as you're reading the story through the chart of what's going on. You don't have to code all of those things, of course.
Okay. Yeah, I happen to see that a lot with a lot of breast cancer, where they use abbreviations, I guess, and I didn't understand how that process worked, but I guess I should actually look into that, because that is probably more frequently done than I realize.
I think the overarching message here is practice, 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 and dig in, dig in, dig in, right? You're not going to learn it overnight.
Yeah.
And just about the time you think you do, there's new treatments, there's new ways of doing things, there's new ways. So you've definitely got to be a person that is attracted to the type of changing situation and changing treatment, that you're not afraid of change, and you're willing to learn that and continue to learn that. A continuous education type thing. Yeah.
All right, so let's talk about daily routine. So Susan and Heidi, what is your typical day like? Do you have some kind of pattern you follow when you code, or are there like a lot of surprises in your workflow that you have to deal with, and do these things make your job interesting?
Well, for me, I specifically code for physicians. Radiation oncology is a little unique in that the technical components and the professional components are often completely different codes, as opposed to, there are some that are a professional technical component split on the same code, but they work from very different parts of the code set for many other services. So I will review the list for the day of patients for the charts that I have for each individual patient. I will look at the steps in the process of care to make sure that I'm not missing charges for any, because for every patient you're going to have a consultation, and the typical flow, you would have the treatment planning, then a simulation, and then you would start the treatment delivery. And then afterwards you would have the follow-up. So what steps you might expect for the type of treatment being done. So I review for any missing charges or anything that looks unusual to me that I need to take a closer look at. And then I go from there. And then also, because I help to build the services as well, I spend a portion of my day reviewing any denials that come back from our billing or for our business services department on, their coding related denials or that need coding review. So, which is also a great learning experience too. So if you want to learn radiation oncology and you even work the billing or billing edits, billing errors, denials, that can teach you a lot also. Yeah. So I think that has helped me more well-rounded, because I do the beginning coding, but I see the denials come through too. So I really learn the whole process from beginning to end, what works, what doesn't, what are some sticking points. And that's my general routine.
How about you, Heidi? What's in your calendar?
Yeah, I worked for a university system for a while, and they had it divided out kind of uniquely. As you came on as a new coder, you just did the E&Ms, so that you really learned cancer documentation, and then they would train you from there to different modalities. You kind of became an expert, maybe in SBRT and SRS. And so I would, when I did that, I would then spend the day going through the different charges for those and verifying that the documentation was there. And there's a lot of verifying documentation for radiation oncology, a lot that's required by CMS and insurance and everyone. So there's a lot of verifying that everything is there in the chart before you can review the charge or fill it out. So that's probably a good portion of the day. I worked at another place where I kind of did start to finish everything. and helped the AR team. So that was also helpful because I was aware then of like, oh, these things get denied if it's not done this way, or these insurances prefer this. And that's a real education. I agree. That was really helped me see another side of it that I didn't see, when working for a large university. And then we were included in meetings at both places that I worked for, like chart rounds or disease on treatment groups. So you got to know a lot of what was going on with the patient behind the scenes. It wasn't just showing up in the chart maybe. And yeah, you got really the full story of what was going on with that patient. So.
Awesome. So let's switch gears and go back to some coding basics and coding information. So does radiation oncology have, how much of our CPT code set is set aside for radiation oncology services? Is it a large portion that they would have to learn, or is it something where maybe there's, 8 or 9 pages of codes, or what? How does this relate to overall coding?
Well, I would say it's from the CPT perspective, it is a small subset of codes. It's predominantly those a subset of the radiology chapter of the CPT book, with some additional codes here and there for if you're doing brachytherapy or other services. But so the tricky part is not so much learning the actual codes, but learning how they're applied and what the rules are and what documentation needs to be behind them for each modality. Or each type of service, but the code set is small, which I think was the fallacy of when I was asked to learn radiation oncology. I thought, oh, sure, it's this small group of codes. I can do that. And
They tricked you.
Yes.
The old bait and switch, right?
Yeah, right.
But yeah, and then from an ICD-10 perspective, of course, I mean, there are any number of cancer codes and additional complications of treatment and other things that may need to be associated from there. So it is a much larger part of the ICD-10 process. I mean, you mentioned breast cancer earlier. There are I forget how many 100 codes. I just heard that fact the other day, and I forgot the exact number, but it's hundreds of possible codes just for breast cancer alone because of the specificity of, male or female, the laterality, the quadrants. It's amazing just for one condition how many different diagnosis codes might need to be picked up to capture that.
Well, and I think that actually speaks to the quality of the rad-onc coders that are doing this, because as we discover more about breast cancer, right, and there's other protocols for treatment, and there's other nuances with the disease itself, right, it keeps adding more and adding more and adding more. And so it's definitely not an uncomplicated, to your point, Susan, like situation just to sit down and go, no problem, I'm going to code this chart, right? It's digging into that education and being a part of that, actually. Yeah. So
I mean, Heidi, what's your take on the IC10 code set and the CPT code set? Or and I even failed to mention HCPCS, but I think they're out there too. Is there any HCPCS involvement in this process that we should be aware of?
There are. They're not as many as, this. I think ICD-10 takes the cake on how many codes we use for radiation oncology, for sure. And, it also, some of this also depends for what type of a facility you're working in and if you're doing professional or technical codes and all of that. So that's where it can get a little complicated. I agree with Susan. It's not an enormous code set. It's just really learning which codes apply to which modality and the rules around it. There's just a lot of rules. So, but it's not impossible to learn. It's actually, I think it's a really fun specialty to be in. I think it's fun because it's changing, but I enjoy change. So if you do not mind that, it's a great field to get into, and there's a lot to learn. And I was speaking with somebody just a couple weeks ago, and they talked about that they said a new coder, and she'd been doing it for 3 years. And so it just speaks to the length of time it takes to become maybe seasoned in it and really well versed in how things. And I feel like I did it for 7 or 8 years, every day, and still there was modalities. I never touched proton therapy. There's plenty of codes that I've never even used yet. So there's, within those small codes, so much to learn, I think.
Yeah, and that's how you can hook me as a man. You say, we're going to operate the cyber knife. I want to see that. We're working with lasers. I'm there.
Yeah.
We got proton emission fighting cancer. Sign me up. This sounds like interesting as anything I've ever seen in any field. So like that's some things like, there's I assume there's a lot of new stuff coming out, like new gadgets, new cancer fighting things like robotic, robotherapy. But when they talk about things like cyber knife, like I can't imagine that's like some kind of like robotic knife. But in my mind, I think that's probably one of the most fantastic things to see. If you guys want to explain, if you want to walk through what that is, and kind of knock me off my pedestal. But what is cyber knife, so people can like dream about it like I do?
Do you want to, Susan, or do I do?
Oh, you can go ahead.
It's not a knife, I'm sorry to tell you. It's a beam of radiation. It's a modality of radiating. I think it's used a lot in breast. And I'm not fully sure. I didn't do a whole lot of cyber knife, but we did a lot of it on brain where I worked. So the other modalities or the other body parts, we didn't do it so much with. I don't know if you want to give a better description, Susan. It's really just a beam of radiation. It's
it's a concentrated shaped beam of radiation. It's often done in maybe a cranial tumor or a lung tumor where doing actual surgery or an excision is not possible. So they will concentrate this radiation in a way to try to reduce the size of the tumors that are there. So it's as much as cyber knife or gamma knife sounds really cool, like you said, some futuristic movie type thing. It's more a form of radiosurgery where they just concentrate that beam and carve it up.
I've actually seen those many years ago at university, right? The University of Kentucky had one, and this was in the 90s even. And it was like, it was pretty phenomenal, the things that they were even doing then. Yeah.
It is. Well, it's amazing to think of what they can do to treat these tumors, especially when it is not possible to do a surgery to remove them. What a great alternative now that these modalities exist, where 30 years ago, 20 years ago, sometimes even, the way the technology evolves so rapidly that they can really help people in ways that they may not have been able to before.
I know for lung cancer, one of the physicians told us that it used to be preferable to do surgery. That was the best way to treat it. And then secondly was radiation. And then thirdly was chemo. And they got to the point with SBRT where for patients who really couldn't tolerate surgery for one reason or another, the data was showing it was equally effective to surgery. So that was really exciting because they still had the same shot at treatment and cure that somebody who could have surgery had. So I think radiation oncology is exciting. They've become so precise with where they can get the cancer and spare the tissues around it and really protect. I think about like my mom had cancer, 25 years ago. And when she was radiated, it was a huge area that was radiated. And now it would be such a smaller area that they would do. And so you wouldn't have the scarring and the damage. And yeah, it's fun to see it kind of behind the scenes as a coder, read about it and learn about it.
Yes, I mean, they can really spare so much of the normal healthy tissue and really just aim those beams at just the diseased tissue without, and my mom also had radiation therapy in the early 2000s. And, I think about the difference in technology now because she did the same thing, had, it was a bigger field because now the machines and the devices and everything that they can do is just advancing so much, even in 20 years. And 20 years from now,
Right.
who knows what'll be out there? I mean, it's changing every day.
I'm still got my money on Iron Man suits. Doctors are going to have like fully functional laser beams on their fingers where they just point it at the cancer and cancer will be gone. That's just
would be amazing.
That would be cool.
Can you all make up the code for that? That would be great.
Category 3. There's a full bodysuit chemo radiation treatment, and then afterwards they sign autographs because they're superheroes, in my opinion.
Yeah.
All right, so let's move on and get and enough of my nonsense. So let's talk about what kind of skills or tools coders should have, or you feel are kind of important to have when you are coding these kind of treatments and these services. Let's start with Heidi. Let's just pick one. Heidi.
Well, I think we already said anatomy and physiology is really great to be well versed in that. But I think someone who's real detail oriented, you really got to look for the details in the chart notes. And I think really just good skills at maybe collaborating with your fellow coders. I just appreciate being able to turn to a fellow coder and say, read this and tell me what you think, because sometimes cancer can be, it's not as black and white as we would love it to be. It can be real gray. And sometimes it's like, what am I reading? Are you reading it in this location? Or are you interpreting it that way? And knowing, I guess, when you need to go to the physician and say, I can't tell from your documentation. Can you clarify this? And then I would say then also with that, you've got to be really comfortable talking to your physicians about it a lot. There's a lot of that they can teach you and a lot that you can teach them when you say, okay, I know from a clinical perspective how this reads to you. I'm going to tell you from a coding perspective. And then you figure out, where the two of you can understand each other and just have the very best documentation, because sometimes it is gray and they throw in their words like likely or suspicious for, and you can't use the cancer code for that. And then that will down the road affect if insurance is going to pay for the treatment. So just really communication skills and detail, really love digging into the details is important.
And if I could interject there and add a couple other little things that I've noticed, I think that there is a certain amount of compassion and understanding that the chart that you were looking at, right? There, as with any other code, there's a person on the other side of that, right? And so that there is an element there that could affect you and make you sad, and you might relate to. And so to have that network where you can just go, I just need to vent for a second. I just need to cry it out for a second, or I need to celebrate because I just saw a chart where someone has made it and they're cleared out, right? They can be very sad charts. And I've had radiation oncology coders who have worked for me that just would call me up and say, I just need to talk. Just give me 15 minutes. And of course, they wouldn't release PHI or anything like that, right? But just to vent those emotions. And, Heidi, yes, I agree with you. The communication skills and that attention to detail. And I think being able to sit down and get into a routine and stay focused so that you aren't being distracted and then maybe missing something because you have to be so detail oriented. Would you all agree with that too, Heidi and Susan?
Oh, yes. Yes, I would agree too.
Yep. So make sure you have a good network and a mentor. Yeah.
How about you, Susan?
I agree. Attention to detail and being able to read and interpret the complex documentation. I think that also, in addition to knowing when to go back to the physician, there's also times where if you don't understand, I found that the radiation therapists and the physicists are happy to help explain things too. And sometimes they're a little more accessible, or, it can take a little more time with you, especially as I was learning the specialty from scratch at the beginning. Uh, the radiation therapists and physicists were very helpful in explaining to me how this works, what this looks like. Because if you're looking at some of those images or the dosimetry documentation, if you don't know what you're looking at, it's like nothing you've ever seen before. All these different colored lines pointing and flowing. And so they're a great resource in addition to the physician, too.
Good point.
All right, let's do a real difficult, deep down into my soul kind of question. What is the hardest part of your job? I mean, because I like to ask and know, because this sounds like it's a very complicated field, but what is the hardest thing? So if any coder can handle this, they can do anything. Like, what is the most marathon type thing you've had to do? And, just a gauge, like a meter of like 1 to 10, what is that 10 for you?
I'd say since I do the whole process start to finish, including reviewing any denials that come my way, probably the most challenging part is reviewing the denials and trying to convey that that it was done correctly, but it's often being reviewed by someone who doesn't understand radiation oncology specifically. So being able to pull together the resources from Astro or CMS or any of those type of official source guidelines and explain what they are seeing, because we've talked about how complex of a specialty it is, and that there's a shortage of people with radiation oncology coding knowledge. So imagine when you're working with someone on the payer end, you're probably getting someone who doesn't know a lot about the specialty. So being able to convey that so that you can be reimbursed and paid properly, that's probably my most challenging part on a consistent basis.
That's a good point.
How about you, Heidi? What do you think is the hardest part of your job that if a person is interested, they would need to tackle at least once or twice?
To be honest, I would say the emotional part is especially when you're new to it. I found myself, I was pregnant at the time, and I was reading these charts of women who had found breast cancer during pregnancy or while they're breastfeeding. And that just, anything that feels personal, if you can relate to it with a relative or a friend or yourself, and you're reading through those charts, it's really, hard. You're human. It's hard not to get sort of sidelined by it or just feel so badly for that patient. And, I think Dawn really said it really well. You have to know when to get up and take a break and walk away, and maybe go cry, maybe just get outside for a few minutes and then come back and be able to enter into it. And then the other thing that I remember my first boss saying to me was, every time you have a pain or something is weird in your body, you are going to think you have cancer. Mm-hmm. And she was not kidding. I can't tell you. My husband was like, oh my gosh, how many times are you going to diagnose yourself with cancer? And you just read so many things, and you start to just feel, so it's just learning to take a deep breath. And I don't know, the emotional part, I really do think is hard, because it can be really great stuff, but it can be really sad stuff that you're reading.
Yeah, I can see that. Let's talk to Dawn a little more, Dawn Norwood. So let's talk job expectations. So what are your expectations for employees in regards to their knowledge or skill set or even mindset?
Yeah. So I think in general, I see it kind of two separate entities. I think that you have directly with the facilities, whether it's physician-based or hospital-based or treatment centers, surgical centers, whatever that is. They have one way of hiring, certainly. And then you have the agencies, which I work for an agency. And generally speaking, the more direct route for newer coders tends to be better, and better for them and better for the hospitals, because they do have the access to those mentors. They are given the latitude to learn. They are, exposed to so many different things. Where as an agency, you really have to know your stuff. Like your ramp up period is to maybe learn a nuance in their system, right? Otherwise, they need you to come in and sit down and know exactly what you're doing. And I'm very sympathetic to new coders, because I always hear, I can't get the job because I don't have the experience. But how can I get the experience if I don't have the job, right? And I always encourage new coders or those wanting to learn a different field, like what we're talking about, go to the source. Go to the source. Find a mentor. Be open to learning. Be open to new experiences. Just try it. Try it. Obviously, commit to it. Commit to it and really dedicate yourself to it. And I think especially with coding like RadOnc, where it is so detail oriented and it can be so difficult, that it's even more important for you to surround yourself around good coders and good mentors, right? So that they lead you down that right path. So, but across the board, always professional, always communicative, always do what you say and say what you do, right? Like, if you're going to, we all work mostly remotely now, right? So it's going to be extra effort to be able to communicate well and to let your supervisor know where you are, let your mentor know where you are, reach out when you're struggling. There really is a lot more pressure, I think, now that we're, mostly remote, to make sure that those pathways are open. Continue to seek education through AAPC, AHIMA, all of your credentialing bodies, right? Continue that education. Come into webinars like this, explore. I think in this field in general, that is the one thing that those coders that are successful have in common among the intangibles, is this desire to learn and to help, and to understand that what you are doing is not just about the bottom line, it's also about that patient impact. Yes, that is a byproduct, that the patient does great, the hospital has a better bottom line, but it impacts so many more in the community. Because if you as a coder understand that what you are doing also affects your communities and your hospital's ability to provide new services, right? Maybe they haven't had a good RadOnc coder in the past, and now all of a sudden you're there and you've learned it and you've taken the time to dig in. Now all of a sudden those services, maybe in a smaller community, are more widely or readily available to someone who couldn't drive 2 hours away. So I think understanding the importance of what you're doing, and that's across the board, but especially in modalities like this, because it does have such a huge impact. So just being super professional and communicative and eager to learn would be my advice. Would you all agree with that?
Yes, I think that was a good point that Dawn had. I try to strive for as much accuracy as possible and to minimize denials, because you know that every time a claim is denied, that patient gets the EOB too, and they are stressed out, they are under treatment, they do not understand when they get their EOBs to begin with, and if you want to cause them as little stress on your end, in your small corner of the site of their treatment, you want to make sure that things go as smooth as possible so that they are not affected.
And Susan, I think that's an important mindset, to understand that you are part of their treatment process, right? That you are not just a person sitting at the keyboard typing in whatever, right? You are a part of that process, and that I think is very impactful. And to Heidi's point earlier, part of that emotional part of it too, right? And that responsibility that you have on your shoulders for doing it accurately. Yeah. Thank you, John. Yeah.
So let's talk about the flip side of it. So let's talk about red flags. So we talk about what you look for in a candidate, but what do you look for that might be discouraging in either a coworker or a candidate or a team member? Like, what are some things that might, send off those red flags in your head?
Well, I think from my perspective as a recruiter and watching my recruiters recruit, right? Um, I think it's a lot of it is the lack of communication. Because if you are, I at Norwood we run a very much of a relationship based type recruitment. So when you're speaking with a consultant, it's important to find out what their needs, what their wants are, what their pathway, what their career, what they want to look like, right? And it's your job to help them down that path, right? So when you're speaking to a recruiter or you're speaking to a hiring manager at a hospital, and the first thing they say is, well, this is your job and this is what you're going to do. Now get to it, right? They're not thinking long term. So I think those relationships and the lack of effort to establish those relationships with a partner, right? Like, I'm not a coder. I know just enough to be dangerous, right? But I rely on my coding consultants to help me learn so that I can better take care of them and put them in situations where they're succeeding. So a red flag for me would be someone that ghosts, that isn't timely in even getting their information back to you, that is reticent to learn new things if they need to, right? Like, I've done it this way for my entire career, and that's the only way I'm going to do it. This is probably not the pathway for you because medical things change, medicine changes on a daily basis. So, if they're not good with change management, that can be a red flag. Can you coach through that? Sometimes, yeah. But I think that is also where it comes down through to the relationship that you have with either your supervisor or your recruiter, so that you can express that you're frustrated, but they can also come to you and say, hey, I know you probably didn't mean to do that, but this is what happened, and let's work on this together, right? So there's tangibles and there's intangibles, but the obvious ones are just even something as simple as turning in your timesheet on time, right? And I know that sounds ridiculous, but it's actually kind of a telltale sign of how you are going to perform for the client, for the consultant, for the client, the hospital. And are you going to do everything that you need to do for that patient? And so I think it's dotting your I's and crossing your T's, and not doing that isn't always a huge red flag, but it definitely gives little inklings into that person's maybe work ethic, right? Yeah. So that would be my take. I would say that Heidi and Susan probably agree with that in some form or fashion, right?
Mm-hmm.
But also has some probably red flags, more of the technical part of it. But yeah.
Yeah. How about you? Because I know I'd probably be an awful coworker or team member because first off, I'm loud. I mean, you guys have heard me talk all day. I'm loud and I'm obnoxious, but and I'm also horrible at math. So I don't know if that's a big deal for your team. But what are some things that, like, if you have a coworker that, like, there are certain deficiencies that you wish you had known about when they were hired?
I think that somebody who was resistant to change, who wanted things never to change. They wanted a process that was black and white and that they were going to follow every single time and never deviate, because there's always change. Depending on the patient, things could change. Their treatment could change mid-course. You might start off thinking they're getting one type of treatment, and their health changes, their condition changes. There's a new metastasis or anything like that. And so what you thought you were doing with that patient all of a sudden changes and starts over again. Or, well, we know that the code sets change every year, but also regulations change. The NCCI edits change. CMS was going to change the way that they reimbursed radiation oncology a few years ago. It was tabled, but it's coming again, and that will have some change. We don't know what that will be. So if you don't deal well with uncertainty or change, you might struggle. So that would be good to know in advance as well.
Heidi, you're up.
Well, I agree. Maybe healthcare is just not, in general, not a good place if you don't like change, because I don't think it's limited to just radiation oncology for sure, obviously. But yeah, that would probably be the thing that makes the hair on the back of my neck stand up, is when somebody says, well, let's just do it this way because that's how we've always done it. That phrase, I'm like, oh no, that doesn't work. And I guess beyond that, just when I've trained newer coders, I think the ones who are really successful are the ones who just really have like that lifetime learner. You're willing to learn new things. You're willing to accept that it could get more complicated, or there could be a new modality that we do, or it kind of goes along with the change thing, I think. And if you're willing to learn, then you're also willing to kind of research for your patient that you're coding for. You got to really dig into their chart sometimes and go looking. And I think that learning also translates over to getting along with the physicians. You come to them with a learning perspective rather than a telling them perspective. And if you do that, I found that, they tend to work well with you and listen when you have something to teach them. So yeah, flexibility, maybe that would sum up all of that.
Yeah, systems are down sometimes, especially being remote, right?
Yes. Yep.
Yeah.
So let's talk about the question I know is on everyone's mind in the audience: 2-year requirements. I know this is a very tough topic and it varies from place to place, but can we get your input on that 2-year requirement for coding experience? And what are some things that might outweigh that or offset?
So from an agency perspective, typically nothing, to be quite frank, because as an agency coder, as I've mentioned before, you've got to have that experience down pat and be able to walk in the door and sit down and code, right? With that being said, I think that there is a lot a person can do to get themselves to that point. And we've kind of touched base on all of these things. We work remote. You don't have to just apply to hospitals in your area. You can apply nationwide and do apply nationwide. Always. There are mentors all over this beautiful United States in our hospitals and in our physicians' offices and in our surgical centers. There are people that are willing to teach. But you, as a new coder, also have to know you've got to start here. Right? You got to start here, and then you grow and you compound on top of that. From an agency perspective, because, it's kind of like we're the SWAT team, right? We come in when things aren't going great, whether it's a backlog or it's, a new EMR system that's being implemented. I know everybody's face cringes when we talk about implementation, but it's true, right? Like when those things happen, maybe it's an acquisition, maybe it's, back when ICD-10 kicked in, it was a huge time for that, right? And there's a time and a place for everything. And you can build your experience up. And some people spend their entire career working for, direct systems. But other people also like to try the contractor part. And that is also very stable as long as you're with a good agency that looks out for you and wants to keep you working, right? It's not transactional. But I think overall, there is a place to start. Pick your schools carefully. Pick your credentials carefully. Pick your mentors carefully. Network like crazy. Network like crazy. Go to HealthCon, right? Go to the HEMA shows. Go to your local chapters. Attend webinars like crazy. And then when you have that one job, be that person that volunteers and says, hey, I would really like to learn ED. I would really like to learn same-day surgery, and I would really like to learn whatever that is that you really want to learn. Be that person that goes to them. And if a foot in the door means that you are going to, to Susan's point earlier, start in denials, right? Like they're going to, or start you in whatever that is, take it. If they have a good mentoring program, take it. Because the more that you get entrenched into that and the more that you prove yourself, the more people want to teach you. And the more people want to impart that knowledge and their legacy to you. Right now, I can't hire someone with less than at least 3 years of experience, sometimes 2, depending on what we're looking for, right? But that's also because that's the agreement that we have with the hospital system, right? So it's not as personally, it's the agreement that we have with the hospital systems. But you can apply all over this United States and go do that. And just find yourself someone that you really connect to learn. And you'll get there. It will pass quicker than you think. It will. Susan and Heidi, do you all agree with that? Like from an experience perspective, like, it's not that I'm personally saying I can never work with you. It just, I can't yet. And that's what I always like to say. I can't yet. So.
I do agree that, you can look for jobs anywhere, but also if you are brand new, you may find someone in your local market willing to give you that first entry level job because they want someone who they can go hands on. I know that my employer will hire new coders. They'll hire CPCAs, maybe not in every specialty, but there are entry level positions, but they will start off in the office until they're comfortable with your skill. But if you're brand new and you haven't coded before, maybe that's okay if you're open to it because you can learn and be mentored and then be released to home at some point. I know that coding, like everybody wants to work remote, but don't close your mind to the possibility of doing some time in the office if you're brand new, because you can learn a lot that way too.
I agree with you, Susan, 100%. Yeah. And I think that this goes back to what we talked about earlier, John, is that this is an investment, a continuous educational investment, right? And it starts from the day that you enter school and it never stops. It never stops. So if you're the type of person that wants to, well, I went to school and I learned it and now I can do it, that's not realistic. Because by the time you even get out of school, we've already got new coding books, right? We've already got new guidelines. We've already got new procedures. There's all kinds of new things, right? So it's being able to be open and willing, and then it becomes enjoyable. It becomes enjoyable because you find a passion in it. And then it doesn't feel like 2 years. And then it doesn't feel like 3 years. One of my very first coding employees, when I started in mid-revenue cycle, I've been doing this for 23 years, but in mid-revenue cycle since 2010, so almost 14 years now. And my very first hire in mid-revenue as a coder, she still works for me to this day. Wow. But I'll call her. I'm like, I need some help understanding this, right? And she educates herself too, right? And she had experience prior to me even hiring her. So it has never stopped as an educational type thing. Don't give up. It's worth it. But find the right people around you. Surround yourself with your right tribe. Get your tribe around you and you'll learn. Yeah.
All right. So once that coder finds their tribe and finds that home and they learn the fundamentals of radon and they actually do excel at it, what's the next step? Like, what's the next level of advancement in radiation oncology?
Susan and Heidi, you want to take that one?
I think you kind of work your way up the coding ladder, coder 1, 2, and 3 sort of a thing. As you, especially in a field like where it's more specialized, depending how you're trained and how your facility does it, they might release more responsibility. You might get to know more modalities for rad onc particularly. And then I think after that, you start to train the ones coming up behind you and teach the new coders and mentor them and become a mentor yourself. And, from there, I suppose kind of the sky is the limit. You can go into auditing, or you can go into cycle management. You can move up into manager position. You can become an educator for a physician educator, when you know your stuff really well. I think there's a lot of opportunities out there that are it's just kind of more than you could probably name. Once you start dabbling, you realize, oh, I could do this. And when you get another certification, now I qualify to do these two things here also. And, Dawn at the beginning mentioned, you don't pigeonhole yourself, which I agree with. But I also will say the flip side of that is I thought I had pigeonholed myself with radiation oncology. And then when we were moving and I was putting resumes out there, I realized I had actually put myself in a niche and was high in demand. And I couldn't get anybody outside of Red Onc to look at me. And I was like, what's going on? Which was kind of fun to realize, like, oh, there's a demand for this out there. So you can become, very valuable.
Very valuable.
Yeah.
I agree with you, Heidi. And when I was talking about pigeonholing, for a new coder, right? Like try it all.
No, I get
it. Exactly. But you're exactly right. And I think what's beautiful about the Red Onc part of this is that, and with coding in general, is that you don't necessarily become pigeonholed once you have that experience.
Yeah.
Right. You really, like you say, I became specialized. Yeah. And that, I think about like people with CERC code certifications, right? Very hard to find them, but man, are they in demand, right? Yeah. And those interventional radiology and the Rad Onc coders, where new, especially for cutting edge, right? Those types of fields where it's cutting edges and it constantly changes. And Heidi, to your point, it's about the learning and knowing that you're like, oh, let me try this part. Let me try that part. Let me get good at this one and move to the next one and continue to get better and better and better. Now you become quite the exception, right? And you are highly desired as an employee for sure.
That time does fly, like you said. Time flies while you're in the process of going through all these steps. You look back and you're like, wow, I didn't like in the blink of an eye because I've been so busy learning all these things. It goes by quickly.
Yeah, absolutely.
How about you, Susan?
Yes, I would agree. There are so many directions that you can go through. But radiation oncology specifically is a great niche. If you have a good foundation in coding, in a broad foundation in coding, and then specialized, I do think the sky's the limit. There is room for educators. There's room for people who are knowledgeable about compliance. There's room for management. It just depends on which path you want to take. And it's always important to keep learning, and you can learn the different modalities. You can learn, you go from being facility physician coding. There's a lot of directions that you can go to, but I do agree that it's in demand. I constantly have different people reach out to me. Do you know any Rad Onc coders who are looking for a new role? Can you refer me to them? And I'll do what I can to put the word out, but I do think that there's more opportunity than there are people with experience. So I feel really grateful that I had the opportunity to fall into some experience in Rad Onc without that background. And it all comes from back to what we talked about, being involved with other coders and getting to know them and building your network, because then if they know you and they have an opportunity that they can't fill, they may tap you to learn it, which is what happened to me.
Yeah. I think it really comes down to that, like making it personal, right? And getting to know your network. People want to hire you. People want to teach you. People want to do. And to pass that knowledge on. Yeah. Just be an open vessel.
We're winding down a little bit, so let's talk about some resources for learning. So learning resources. Where can some people go to learn about radiation oncology coding? Are there websites? Are there are there reference books that you recommend or places they can go to get that leg up?
Yes, Astro is a great source, the Professional Society for Radiation Oncology. They have coding guidance on their website that is open to anyone to look at, but they also have the book, which is probably the gold standard for that, the coding guidance book, which I think is very helpful. I'm also a big fan of the Navigator for Radiation Oncology book from our CCS. The revenue cycle coding strategies. I love that book because I do think that it is laid out in a way that makes it easy to learn and read through the whole process of care. And I refer back to those books regularly, even with experience, because I constantly am learning some different nuance that maybe I didn't realize before and that I'm just building off of. And then also, of course, know your CMS guidelines and your NCCI edits and any of your compliance rules, your payer guidelines, because of course, there's the proper way to code it. And then there's the way that, some payers want it a little differently, a little more nuanced. Maybe they don't want the Z codes. I mean, you have to get to know your payer mix too and what you need to do. So all of those things.
How about you, Heidi? What do you use in your, or what are some resources you recommend to new coders or any coder interested in learning radiation oncology?
Well, I second Susan, the Astro website and their book and the Navigator books. I have found those to be super helpful. They have an oncology E&M book, which is helpful for that side of it. And they have kind of a billing compliance for radiation oncology, in addition to just all of the really detailed explanations for the codes and when you can use them and when you cannot. And just really explains things really well. There is a RADONC certification you can get. It's not through AAPC, and I cannot remember the organization that does it.
AMAC. Yeah.
Okay, AMAC, there you go. So, that's a resource if you really want to become specialized and get some extra letters behind your name.
And AMAC also, they do have the radiation oncology certification. They have some great webinars too. I learned they have one, it's the core compilation for radiation oncology, and it's a 3-part series of a webinar that's available on their website. And that is very helpful and very detail oriented. And I still go back and look at my notes from when I looked at that when I was first learning too. So.
All right. So let's touch on that. So I'm going to ask this question, then I'm going to circle back to Dawn. Susan, webinars. All right. I see that you have a few planned. Feel free to talk about some of the webinars you have coming up with the AAPC.
Sure. On March 6th, I will be holding a webinar for AAPC on neoplasm coding. And then on May 29th, on radiation oncology physician coding specifically, because that is what I do every day. We'll touch a little bit upon the technical side of it because they go hand in hand, but really drill down and focus on the physician side.
So you do two. One basically on the IC10 portion, like the
yes, the diagnosis coding for neoplasms, understanding the ICD-10 guidelines for Chapter 2 of the neoplasm table, and the codes, the companion codes that go with it, some of the complication codes, some of the additional, the long-term medication codes and history. We'll touch upon all of that. So.
Excellent. And that's going to be actually in like a week. And then 2 months later, you have one on radiation oncology. So coders can look at these and they can find them on the APC website. I'll try to include that information in our comment notes about this presentation, and you can look at that. But I think that's going to be a good way to get more of a feel of the technical aspect. But we didn't touch on tonight. We touched on a lot of the kind of social aspects of the process, but technical, there's a lot of information out there, and she's going to have 2 ready for us. Now let's circle back to Dawn. job rise. There's a lot, like you mentioned, that you guys have a need for radiation oncology. So I'll let you plug your own Norwood company and talk about that for a while.
Thank you. I appreciate that. No, we do have radiation oncology opportunities available for experienced rad-onc coders. Anyone, regardless of whether it's rad-onc or any other specialty in coding, we are consistently looking, including some future but upcoming risk adjustment type situations, outpatient CDI. We have a number of opportunities and ever expanding. So if anyone is interested in even just hearing about how Norwood does things a little bit differently and how it's more relationship based, please feel free to send your resume to info@norwood.com. Just info@norwood.com. Thank you. And I'll be happy to have a recruiter reach out to you and discuss what your career plans are. And see if we're a good match, because we want to be, you're interviewing us as much as we're interviewing you. We want to make sure that it's a good fit for you and that we can help you not just right now, but in the future as well. So yeah, thank you for that, John. I appreciate that.
And that's what we're here for. We're here to connect coders with jobs. And that's the whole reason for this series, to see if you like it, see if you can do it, and then put you in contact with the people that can make that happen. So any last minute comments on radiation oncology in general, Susan, Heidi, or Don, before we check out for the evening?
I've learned a lot tonight too. Thank you, Susan and Heidi. I appreciate that.
Yeah, I'd say go rad-onc. It's a fun field, you know. If you're up for learning, go learn.
There's a good
it's very interesting. It's really interesting to learn the modalities. There's always something to learn. I've watched some YouTube videos of physician lectures just because it helps learn the technical aspect of it, and it's just a fascinating field, what they can do to treat and the advances that are coming and that are being made every day. So I really enjoy learning about it, and I'm glad that I lucked into this specialty.
All right. So if you have any questions, Susan's on LinkedIn, Heidi's on LinkedIn. Dawn is also locatable on LinkedIn. We're on their website, www.norwood.com. If you have any questions, they're the ones that could possibly field those and help you in the right direction. They can be those resources that you need, or they can tell you where you should look. So again, I'd like to thank everyone for coming. And we're going to take a little break next week because there's also a planned hijacking of me. But the following week, we're going to deviate from our coding role discussion, but we're going to talk about coding media. So I'm going to leave it at that and let your imagination run wild as to what I'm talking about. So I'm going to post about that next week. But yes, we'll be talking about coding media. So thank you guys for coming out and having a good night.
Thank you so much.
Thank you for having us.
Yes.